Hello, my name is Bill Boissonnault. On behalf of the Academy of Orthopedic and Physical Therapy, I want to thank you for joining us as we continue our 50th anniversary time travel adventure. 2024 is the 50th birthday of the Academy, and we are undertaking a number of activities to celebrate and honor the past, key people, key events. And one of the activities we're doing is to highlight certain events that not only impacted and help shape the Academy, but also help shape the profession. Today's topic falls within the arena of advocacy and in the legislative arena. And the event itself was the creation and subsequent work of the APTA Manipulation Task Force. This was primarily driven by the Academy, APTA, and the American Academy of Orthopedic Manual Physical Therapists, or AOPT. And it was driven by a huge bump up in legislative challenges by the chiropractic associations. So we are joined today by two individuals who were heavily involved in the creation of the task force and the subsequent activities. First, Dr. Justin Moore, who's currently the CEO of our American Physical Therapy Association. And in the late 1990s, 98, 99 is when Justin joined APTA, and one of his main roles was state governmental affairs. And the second person, Dr. Steve McDavitt, who leading up to the 1990s and beyond has really been in the trenches at the forefront of these challenges and how we can best prepare to meet these challenges. So, gentlemen, thank you very much for joining us today. So, Justin, let's start with you. Kind of a big picture question. How do we get such a big target on our back from the chiropractic associations? And can we describe the scope of the problem? What was driving the chiropractic pushback?
Yeah, it's a great question. I think we were developing a lot of research and a lot of practice expertise in manual therapy. And so in the late 1990s, I think the chiropractic profession started to see the role of physical therapists as leaders in this area of practice, and made a legislative initiative to begin to try to attempt to control who could provide manual therapy and manipulation. So you talked about us having a large target on our back. I think at the height of state legislation, over 30 states introduced legislation that would have made manipulation, grade 5 mobilization, the exclusive domain of the chiropractic profession. And so that's really, the late 90s was when this target got on the back of physical therapy, and the profession rose to that occasion and really defended our right, and not only defended our right, but really showed our leadership in this area of practice.
Yeah. And Steve, from your perspective of being in the trenches, again, thinking about this big target on our back, and what else was driving the chiropractic associations?
Well, yeah, it was a big target. And I think, at least in my experience, it was the first time I'd ever considered or being involved in advocacy in such a wide scope, because the chiropractors, they really were professing that their practice tenet was unique as physicians in non-medical spine care, specifically as it pertained to spinal manipulation. And, it was hard because physical therapists didn't run around talking about, individual techniques. We talked about treating patients, even though that was one technique of many. And so it became a challenge, a global challenge. And not only that, because in terms of the states, but not only that, but it really, even though the chiropractors were focusing on manipulation, it was affecting our direct access legislation. Yeah. So it wasn't like it was just PTs trying to defend manipulation. Manipulation became such a big piece of that, of the hindrance of direct access. And at the time, I was involved both with the orthopedic section, now the Academy, as well as AOPT in terms of practice. And there were huge demands on and efforts from both organizations to provide our colleagues with how to defend it and really how to confront it. And so not only was APTA recognizing and appreciating all this confrontation, but we were actually experiencing it. So to us, it was being in the trenches, the alarm bells were going off, and that really sort of said, what are we going to do really as a group together to kind of deflate this effort?
Yeah. Yeah, you're right. It was tied to direct access in many ways. There was a big chiropractic think tank that produced a paper in 1998 and then again in 2005, the future of chiropractic. And they describe in there about the push within the physical therapy profession toward the DPT, as well as for direct access. And even though we always kind of knew this, it was the first time that they really put out in public that they viewed us as the number one competitor to the services that they wanted to provide and they wanted to hold on to in terms of turf. Steve, maybe I'll come back to you and then to Justin again. So what were the chiropractors saying about our ability or inability or our lack of education that was what they were saying in public, why we shouldn't be doing joint manipulation types of interventions?
Okay. Well, it really was, a lot of it was based on what they felt was our competency and our ability to not hurt the public. And they had leverage because, as we all know, a common statement we use all the time is perception is often reality in the legislative arena. And so the chiropractic public relations legislatively had identified them with spinal manipulation because when you really think about it, what does the public think about? They think of manipulation of the spine when they thought of chiropractors. And so they were synonymous terms. And so the other leverage they had was that even manipulation, their sort of promotion was even manipulation provided by physical therapists was the practice of chiropractic. So now we had to figure out, not only do we have to figure out, number one, that we have competency, education, and training, but number two, how do we now say that this is part of our practice and not the practice of chiropractic? And so, they were basically putting out there that we were not trained. We didn't have the ability to do it. We didn't use it. Some were doing it, some weren't doing it. And it was part of chiropractic, but not part of physical therapist practice. And so then that became the whole issue of, in the debate, is it mobilization? Is it manipulation? Is it thrust? Is it non-thrust? And all these terms now became sort of trash canned out there to, if we said, yeah, we could do mobilization to grade 5, well, is that thrust or not thrust? So we'll get into that, I'm sure, in this discussion, but those are really, the crux of it really was competency and therefore safety to the public. And then now we've got the chiropractors associated directly with manipulation, them saying it's always manipulation when it's, no matter who does it, it's chiropractic, and they're the only ones safe to do it.
Yeah. Justin, besides adding to that, maybe you could also discuss some of the internal challenges we face that led to the creation of the task force, as different jurisdictions were taking on these challenges.
Yeah, I think that, the biggest challenge we had as an organization was not only what Steve described as how to protect PT's ability to perform manipulation through we're safe, we're qualified, and it's not uniquely chiropractic. We also had to prevent the political gamesmanship that it wasn't used as a chip to negotiate against our other priorities. And that's the direct access conversation. So our biggest threat in the profession was primarily around that, was really ensuring that we didn't mistakenly give up a recognized area of our practice in pursuit of our other objectives, direct access, licensure, and things of that nature. And so that's why the trifecta of the expertise from the section, now the academy, the unique expertise from APTA, and then APTA could provide the communication vehicle and the infrastructure, became our way to defend this. Is our role at APTA was really to help take that expertise and translate it so that it wasn't lost in translation at the chapter level or at the people who might be our legislative chairs in the state who don't practice in this specific area. And so there was training involved on both how to testify, but also how to understand that safety issue, that quality issue, and that this is not uniquely chiropractic. Many professions use manipulative techniques, osteopathic physicians, PTs, chiropractors. So how do we prepare, and APTA was in there, how do we prepare our advocates to be able not only to defend this, but to articulate the unique policy foundations of this issue?
Yeah, you mentioned, so some of the internal challenges that there were some chapters that were considering negotiating away parts of our practice in the pursuit of direct access. But I also recall a number of instances of inconsistent messaging, as chapters would try to fight back against these challenges. And so there's inconsistent messaging. There was unawareness of the resources that were available kind of across the board within our jurisdictions. That was also some of the challenges that we tried to overcome by putting this task force together. So Steve, maybe if you could describe some of the processes and the frameworks that the task force put together initially to try to address some of these issues.
Yeah, and I just, in stepping into that, just like to add that, we have to recall also that the guided physical therapist practice was in its infancy during this time.
Right.
So it wasn't like we could say to somebody, go look at the guide for some of the operational definitions of manual therapy manipulation to techniques to defend it. So that became a challenge in itself. And also convincing other PT stakeholders that this was an important component of all physical therapist practice, because, let's face it, if manual therapy manipulation was a minor thought, this was significant resource expenditure coming back to different components to defend this. And so it was important to put a value on that as well. And so all of that brings us to the next component, which is what do we do with the task force? And, so we actually had a conference call somewhere. I want to say that I guess it was somewhere around June or so of '99 to sort of come together and, Ortho and Government Affairs and AOMP to say, okay, what is it that we're looking at and how can we investigate this? And so we had to really look at, are there materials that are available right now we could distribute? Are there materials that we needed? Are there strategies that we need? And so from that conference call, we decided that, and this was some of Justin's really great work, because developed a questionnaire in a very short period of time, like 5 weeks or less, got it distributed to the membership to investigate, are there problems we're not seeing? Are there materials that we need? And also, what do you understand about the current materials that are available? And it was from that we then had this meeting of the task force to say, what strategies can we now move forward with in terms of how we're going to address different issues? And those issues really were related to regulation, legislation, education, practice, components of the House of Delegates, and state chapter funding. So I see funding for PACs, et cetera. So I think from a standpoint of that, the task force then had its feet on the ground to then come up with strategic planning to move forward. And lastly, I'll just add that from that point forward, once it was determined to be a task force, we met every CSN and every annual conference, providing opportunities for components to meet and share war stories and also update themselves on current issues and how we're managing them.
Yeah. Justin, anything to add to kind of thinking about the original processes that were put in place and the frameworks that were put in place by the task force early on?
Just adding that this was all new. I think Steve hit a great point that the guided physical therapy practice was 2-3 years old at this time. And so advocacy as a profession was also very much new too. And so a lot of states had gone for direct access, but remember, this was happening simultaneously to the therapy cap, which was also an awakening of that you need to be an advocate as a professional. And so that gave us some good tailwinds for people to get engaged in advocacy at the association beyond just the singular issue that had defined us, or the singular, couple issues of licensure and direct access. This became a real broadening of the net of building advocacy muscle and capacity as an organization. And I think that's key, because this is one of the best examples where we really took an iterative process. We said, what's the compendium we have today? How do we improve it? What do we need to prepare people to testify? And it really became evolutionary over time as we kept building these documents and making sure that they were enhanced and shared. And those were the two things, that we had the best resources available and deployed to the problem, but then we also got it into the right people's hands. And that took a very, concerted effort by the volunteer leaders and by the association to make sure we used those channels of distribution, those relationships with the components, to make sure we were on our A game. And I think at the end of the day, it worked. I mean, we entered the battle with 3 states that had restrictions on manipulation, and today we have less than we've ever had. And we didn't lose any of those state legislative battles at that time. And now we're more proactive in making sure this is part of the Model Practice Act. This is part of when you're going for legislation that you really look at the language that's most contemporary to define physical therapy practice.
Yeah, I mean, both you bring up not only the short-term outcomes, kind of the report card of this group, but also longer term. Yeah, from what I recall from the task force, two main things. One, we took a really good look of our house and what needs to change within our house to better prepare us for these types of challenges. So the guide to physical therapist practice, we created a manipulation education manual, again, to promote some consistency in terms of language and terminology, even at that level. And also for communication, Steve, you mentioned the meetings that are national meetings that were attended by components and APTA Academy and AOMP staff. But we really pushed that if a state was facing a challenge, please let the task force know. So it came into APTA so that we could generate the resources, put in a package for them, what specific complaints were they hearing. And so I thought the lines of communication were much better as this task force took hold. That led to more consistent messaging and I agree, better outcomes over time with that. So in terms of, Justin, you alluded to that the task force work seemed to work. It's no longer in existence, not because it didn't work, because we had success. Justin, can you give an overview of the type of legislative pushback with joint manipulation or direct access we've had in the last 5 years compared to 25 years ago?
Yeah, I think 25 years ago, we were fighting just basic recognition of PT issue in general. So as Steve talked about earlier, this started with a really difficult PR issue, is how chiropractors came to the table with a very clear association between their profession and their technique. And we did not have that. So people didn't know who we were, what we did. And what's really changed over the 25 years is we are much more known for our expertise in practice in managing patients. And that has really helped us across the board, whether it's defending manipulation, whether it's dry needling today, whether it's EMG. And so as you have other practice techniques or interventions that are out there, people come with a base knowledge now that physical therapists are trained and qualified at a certain level. And that's been the real evolution of our advocacy efforts. We're working from a much stronger base of support of who we are as a profession and the value we provide to patient care, and that our techniques are part of a treatment plan. We're not defined just by the technique we use, but these techniques are part of a comprehensive patient management model, which goes all the way back to the guide.
Yes. Yeah.
I think another important point is it also allowed us to replicate the success of manipulation in other areas. So when we find a threat, we came up, and the manipulation was part of this. APTAs at that point created action packets, and manipulation was one of the 9, but it's allowed us on scope of practice issues across the board to provide a methodological approach to handling these advocacy issues. And that builds muscle, as we know as PTs. We've exercised that muscle through manipulation, through direct access, through licensure, and now we are stronger as an advocacy organization.
Yeah.
I think also to add to that, Bill, is that I think that our colleagues better understand now that the debates and scope of practice really is that there's scope of practice is developed in such a way that professions overlap now so much that there's really very little unique scope of practice. The issue really is based on the profession's scope of practice as the education and skill development of that practice, which brings back Justin's point about the guide. The guide really provides us with a really good framework explanation about where it is we fit within the regulatory environment and gives us an ability to stand up and defend that. So I think that the strength in numbers and we're better together component has reflected back to this advocacy process, which has showed up, as Justin said, in imaging. Imaging made an education manual for schools, just like we did manipulation manual. And so all of that comes back to many successes that I think that really brought us together, and we needed to do that. I think all of us were in silos as sections. And it's sort of like, sometimes a little thread was good, kind of brought us together and gave us some ideas about how we how we can deal with this as a profession, not just as an entity, as a specialty, I guess.
Yeah. We went from a climate, 20, 25 years ago with us against the chiropractors. And so, Justin, what's the current climate between APTA on a national level and chiropractic associations?
Actually, pretty positive. I mean, we work together a lot on federal legislation because there is just common problems, too much administrative burden, payment compression, and that is not unique to PT. That's across all of our professions. So we find a lot of opportunity to work with chiropractors on issues of that are important to both of our professions, and that is making sure patients get the care they need from the provider that they choose. And so you've seen much more collaboration, especially at the federal level. But I think that's even started to emerge at the state level, as Steve was talking about. There's sort of a recognition that no one owns a unique scope of practice, and that scope of practice is really dependent on that individual's education and competency, and that therefore we have health issues we need to address at the individual and community level, and we need providers that are qualified to do that. So how do we increase access? How do we allow people to practice at the top of their license versus trying to put people in a box defined by others? And that's been exciting from that standpoint. It doesn't mean we don't have turf battles and we're not fighting for space and fighting for roles, but it does mean there's a sort of an elevated conversation at the front end to saying, okay, what is your role? How will physical therapy add to this? We've also seen that play out beyond the advocacy environment and just business climates. There are PTs and chiropractors who have business relationships now and are working together at a community level. So there has been a little bit of a move from a competitive environment to, I wouldn't say it's collaborative yet, but it's at least a more coordinated model. So that's been exciting to see. But we'll still have battles in certain settings, and because there is some unique value propositions that we provide that we think are under leveraged in the healthcare system.
Yeah, but moving in a positive direction, which is good for everybody. Steve, what are you seeing in your arenas in terms of the relationship and the climate with physical therapists and chiropractors these days?
Oh, so much better. And I've done locally here, done some courses, and the chiropractors show up, and of course it's very eclectic, right? We can talk about the technique, and we can talk about the science, and we can talk about what's behind it, and everybody's on the same page. It's just awesome that way. But I think there's also other good signs too. I mean, I really like what Chad Cook has done with ForceNet, because ForceNet now has come together. It really exists as an interdisciplinary researchers looking at mechanisms related to mechanistic management of patients. And it's chiropractors, physical therapists, PhD researchers, all on the same page looking to do good things. I'd also like to say that as I came off of president of Orthopedic, the Academy of Orthopedic Physical Therapy, that during my last year, I worked with the American Chiropractic Association on their conference, their 2019 conference, which was put together to look at, it was forced on looking around the clinical effectiveness and implementation of science in delivery of spinal manipulation. And so it served as a platform, of an interdisciplinary platform. So there were physical therapists, osteopaths, and chiropractors all on these panels for a 1.5-day conference. And we had 3 PTs, 3 DOs, and 4 chiropractors on the planning committee. Pretty cool, I think, for collaboration. And 5 physical therapists provided 6 presentations in that whole course, that whole conference that was focused on spinal manipulation, science, and implementation. So I think that the writing's there. I think what we should do now is continue that relationship and continue to sort of breed that, and I think we'll see far less confrontation in the future. I think more and more we're realizing similarities, and yet there's enough there for everybody in terms of practice.
Yeah, you would think so. Another example of how we're being tied as professions together, some of the opioid literature that has come out, and the initial entry point for patients, who they see initially makes a difference if they're prescribed opioids and go on to have opioid misuse, abuse, and addiction. And we're often, lumped with the chiropractors and acupuncturists as kind of the non-physician portal for patients in particular with chronic pain and back pain. And like you said, I think there's enough patients out there for all of us. There is overlap in our approach, but Justin, as you mentioned, we still have some differences, and we need to protect that. But I'd like to think that we'll find more and more collaboration with some of the larger healthcare provider issues that we're all facing. Any kind of last final thoughts, behind the scene things that never would have made it out into any of our publications related to the task force or subsequent work related to these legislative challenges and the task force? Justin, start with you.
Yeah, one of the things that always comes first to mind to me is how fortunate this profession has been by people who came before us. And, I don't know who made the decision as an association, but choosing the licensure standard has served us well for years. And so when we were battling the battle on manipulation, the fact that we had a licensure standard that said that programs had to teach at an accredited level, and that we owned our accreditor and managed our profession from in that peer management of the profession by the profession was really strong, because that accreditation standard is foundational, and that leads to somebody being eligible to pass a national exam, the NPTE, and that licensure standard really is the foundational to competency. And so we go to Steve's 3 points, is that competency argument was really decades in the making. We didn't arrive in 1997, 1999. We had great foundation based through accreditation and based through licensure. And then we also had great safety. We've partnered with our liability carrier for a number of years, and they gave us data and helped us improve the practice. And we could show that we were not only competent, but we were safe. And those were just instrumental. And that took leaders way before us that were on the manipulation task force, and that to really put that in motion and allow us the ability to build on that case. And we use that daily. That licensure standard is really part and parcel to our whole advocacy efforts, whether it's term protection, direct access, or manipulation. And that was a decision made in this profession probably in the 1950s, 1960s, that really continues to serve us well.
Yeah. Steve, how about you? Any final thoughts or behind the scene things that you experienced?
Well, I think what was really interesting to find out is that, much all these chiropractic papers are written, the irony is that a lot of the information they were using to promote their argument was research provided by physical therapists. And I think that's something we had to keep reminding people. What was interesting is even as anything happens in legislation except logic. And so, even though we explained this in legislation, it still didn't hold a candle to the fact that the chiropractors were saying we weren't competent. So that was a hard one to figure out. But I would say this whole experience in advocacy is it really says the lesson that if you don't advocate for yourself, somebody else is going to do it, and it's not necessarily going to be in your favor. And so therefore, I always say, to me, we have practice, education, and research, but I think advocacy sits within that triangle, and it really gives it its solidification, because without that, we don't really have practice, education, and research, and everybody in our profession owns it. So I think that this experience for me has been one that really showed that we can, in fact, take a group of professionals in the same association that may not be talking to each other and bring them together to advocate not just for their own idealism or whatever it is that their specialty is, but really for all of physical therapist practice. It shouldn't matter what it is. If it's part of our practice, we need to advocate for it. So I think that was a good message. I think a lot of people learned from that message. And I think that showed later on in terms of how these other task forces have come into play. I think it's how people speak now in the House of Delegates, how people think about our practice, and what kind of antenna and sensitivity we have in awareness around us for those things that promote us and those things that challenge us. So I think those were things that I got out of this mostly.
Yeah, I know. I think one of the things that came out of this, and you both have alluded to this challenge and the direct access, how important it is to have a presence legislatively. And so APTA has an upcoming Capitol Hill Day very soon, if I understand. And of course, most states have a legislative day, and it's encouraging to see how many physical therapists, physical therapist assistants, and students are attending these activities to get an appreciation of this arena and how it so closely ties to our ability to practice and education, etc. So it's encouraging that we're having the turnouts that we are in fact having. For me personally, this was about the time the task force was developed in Wisconsin. We were opening up our Practice Act and wanted specific language related to joint manipulation. Part of my role in the practice committee, I would attend the chiropractic examining board meetings. I think we're every other month, and I would attend with our lobbyist. And of course, we just had to sit in the gallery and we couldn't speak unless we were called upon. But there were times they would say things about us that were so untrue, also almost laughable. We couldn't say anything, so I had to sit on my tongue for many of these meetings. But Steve, to your point, they would cite some literature and tie it to their practice, and it was literature published by authored by physical therapists. I wanted to tell them that too, but of course I couldn't until I was called to the table. So it was quite the time. Well, again, thank you to both of you for your role, along with Joe Farrell and Mike Rogers in particular, for creating the task force back then and all the subsequent activities, and certainly what both of you continue to do for our profession. So thank you.
Thank you.
Well, thanks for having us. And so we have a really exciting profession. We have a great future in front of us. Thanks very much.